The majority of patients with prostate cancer are older than 65. The average age is somewhere between 65 and 70. And it's a disease that only people over the age of 50 get at all. So the vast majority are older patients. Those who die from prostate cancer, 70% are over the age of 65. So health status is incredibly important for prostate cancer patients. In many ways, prostate cancer has become more like a chronic disease for older patients. So they're going to live with it for a long time, and they're going to have many treatments that go into it. So how functional they are, the other diseases that they have, are all crucial to how we decide to treat prostate cancer. And there's big trade-offs. So chemotherapies, hormone therapies all impact these other diseases and impact their functional status. As an example, the hormone therapies that are used by, over 50% of men in the course of their prostate cancer treatment make their muscles weaker, it thins their bones, and if they fall down, they're extremely high risk for fractures. It causes a lot of fatigue and decreases their functional status in that way. It also can increase their cardiovascular risk and their risk of getting diabetes. So if they already have those other diseases and they have a slow-growing prostate cancer, you want to think hard about how much you want to make those other diseases worse while you're trying to treat their prostate cancer. Prostate cancer sort of had this explosion of treatments now, and so there's a lot more options too for which ones that can be used. And that is especially relevant if you're trying to balance all these other functional problems and other diseases for older men. All the research in prostate cancer almost automatically has this geriatric oncology piece to it, so it's often hard to separate the two, to be honest. One of the most interesting recent developments is the use of potent androgen ablation therapy, which is intensifying those hormone therapies that I was just talking about. We know that it's extending the lives of the patients in the trials, but androgen ablation can have a lot of side effects that haven't really been studied over the long haul yet. And so those trials are going to have a huge impact for men, because those are men that used to go on chemotherapy are now going to be on oral hormone therapies, and they won't have to get chemotherapy, which will be a good thing, I think. The development of radium-223 as a treatment option for men with metastatic prostate cancer and bony-based prostate cancer was shown to extend the lives even in older men and to decrease the likelihood of having anemia, which is a big problem for older patients, has been going to have a big impact on the field as well. The real question now is how we're going to sequence all of these different treatments for patients. So if we think chemotherapy, we've always put last in the line of things to give. But now if we're going to give them other therapies that seem safer but could be more dangerous, maybe we should do chemotherapy earlier. Maybe we should wait. Sometimes we'll give them vacations from these therapies, and we're still trying to figure out what those sequences are. And there's a number of studies coming out now that are going to tell us which to use first and which to use later.